This is Mrs. Morgan, and we will be discussing emergency and disaster preparedness, what constitutes a disaster, and the different types of disasters. Mainly, our focus will be on the nurse's role during the mass casualty event, but we will also touch on the duties of other interdisciplinary team members as well. A disaster is a serious disrupting event that can occur over a short or long period of time that can cause widespread human, material, economic, or environmental loss, which exceeds the ability of the affected community, society, or medical facility to cope using its own resources. These can be classified as being internal disasters or external disasters and sometimes can occur simultaneously, which means at the same time. This is a list of some examples of disasters. Disasters can be internal, which means that the event has occurred inside of a healthcare facility or on a healthcare campus that could endanger the safety of both clients and staff. The clients and staff may need to be evacuated and relocated. Examples of potential internal disasters could include fire within the facility, explosions, violence such as an active shooter on campus, or perhaps radiation exposure, as well as loss of utilities such as electricity, water, computer system, communication devices, and this could also mean damage to the healthcare facility because of a tornado or hurricane natural event. The most important outcome for any internal disaster is to maintain client, staff, and visitor safety. You have a duty to keep your patients safe even before you alert anyone else. In other words, you move them away from a fire, trigger the alarm, and then attempt to put the fire out using a fire extinguisher. Another outcome priority may be to prevent further damage. For instance, in case of a fire, you would close the doors. Always try to help out the best way possible. An external disaster is an event that occurs at locations separate from the hospital facility or hospital campus. External disasters can be either natural disasters such as hurricanes, flooding, earthquakes, or tornadoes, for example, or they can be technological disasters such as acts of terrorism, for example, explosive devices, or perhaps a malfunction of a nuclear reactor with massive radiation exposure. External disasters can be either multi-casualty events or incidents, as we may say, or mass casualty events or incidents. The difference between a multi and a mass casualty is that of the scope and scale of the incident and the number and severity of victims or casualties involved. You may hear multi-casualty disaster or events, also referred to as multi-casualty incident, MCI, and the same with mass casualty disaster event is being referred to as an incident. A multi-casualty incident is an emergency situation where the patients can be managed by the hospital using local resources. Examples would be perhaps a bus accident or a plane crash where several people were injured that can be treated at a nearby hospital facility. A mass casualty event is defined as an event that overwhelms the local healthcare system, where the number of casualties vastly overwhelms local medical capabilities and may require the collaboration of multiple agencies and other hospitals to handle the crisis event. State, regional, and/or national support may be needed in the affected areas of a mass casualty event. Many have attempted to put a number of victims to what constitutes a mass casualty event, but perhaps the best answer to that is any number of casualties that exceeds the resources normally available from local resources constitutes a mass casualty event. Man-made mass casualty incidents, MCI, means a person or persons are responsible for the mass casualty incident, and examples are listed on this slide, and there are many others as well. Hazmat means hazardous materials, and an incident or accident involves the uncontrolled release of one or more of these hazardous materials into the environment, which could cause a potential human or environmental safety issue. Examples of some hazardous materials may include chemicals such as gases, diesel fuel, pesticides, herbicides, as well as many more other chemicals. The most well-known man-made mass casualty incidences have been the Oklahoma bombing in 1995, the 9/11 incident that occurred in 2001, and the Boston Marathon bombing in 2013. A natural mass casualty incident means that nature is the cause of the disaster. Examples of some natural mass casualty incidences are included on the slide. In history, natural mass casualty incidents have included incidences such as Hurricane Katrina in 2005 that caused more than 1,000 deaths, earthquakes in Haiti and Japan in 2010, and the Superstorm Sandy in New York City in 2012 that caused major flooding. It was considered the second costliest storm after Hurricane Katrina. The types of injuries seen in a mass casualty event is dependent upon the actual type of disaster that has occurred. Blast trauma injuries include fractures, amputations, crush injuries, burns, lacerations, or eardrum damages, as well as others. Blunt force trauma injuries, which is a non-penetrating trauma, includes contusions, abrasions, bone fractures, or ruptured or damaged internal organs. Burn injuries include 1st to 4th degree thermal burns and can result from flames, hot liquids, chemical, or electrical burns as well. Penetrating trauma injuries occur when an object pierces the skin and enters a tissue of the body, creating an open wound. It can be caused by a foreign object or by fragments of a broken bone. Radiation exposure comes from radioactive material and does damage to the cells of the body even before the absorbed radiation exposure dose has been determined. Chemical exposure from fertilizers or sprayed insecticides can cause injury to the skin, eyes, and lungs. Smoke inhalation injury comes from breathing in gases, vapors, and particulate matter contained in the smoke, and it can cause thermal injury to the upper airway, irritation or chemical injury to the airways from soot, asphyxiation, and toxicity from carbon monoxide and other gases. Early intubation is necessary to secure patency of the upper airway and adequate ventilation, which unfortunately cannot happen during a field triage at a mass casualty event. Bioterrorism is the release of toxic biological agents with the main goal of stopping the contaminant. Many times it isn't known when it happens until the agent is transmitted from one human to another and symptoms begin to become apparent. Healthcare workers, especially emergency workers' fear of caring for these patients can pose ethical and leadership challenges and is addressed through safety measures by the use of PPE to protect staff, through focused education, and through the use of evidence-based standard of care. So a nursing priority is to focus on stopping the spread of the disease and preventing contamination to healthcare providers and facilities. And we can't forget about the supportive care and treatment needed until the contaminant is identified. Anthrax is the highest threat of bioterrorism, and as you see from the slide, it is spread through food, water, but rarely the air, because it takes several thousand inhaled spores to cause a dangerous infection. Also included on the slide are the signs and symptoms that the individual may exhibit, as well as the appropriate treatment needed. It's actually a spore-forming bacteria from infected animals that affects the skin and the lungs. Nearly half of all the deaths occur within 24 to 48 hours because of respiratory symptoms. In 2001, there was a series of anthrax attacks through mail, which is cutaneous anthrax, on media and federal government offices, which killed 5 people and caused others to be sick. Government buildings in Washington, D.C. were shut down, and the government agencies were educated on how to handle suspicious-looking packages by wearing gloves to sort through the mail. This was when the worried well, which we will address on the next slide, flooded the medical facilities with common cold symptoms, thinking it was anthrax. One positive aspect of anthrax is that it is not contagious, meaning that it cannot be passed from one individual to another. A pandemic is an infection or disease that occurs throughout the population of a country or the world that leads to a vast number of people seeking medical care, thus overwhelming the medical care facilities. Many times the spread worldwide is associated to travel. The Ebola outbreak occurred in West Africa and was spread through body and blood fluids. Initially, the signs and symptoms were fever, headache, muscle pain, and chills that later progressed to internal bleeding with vomiting and coughing up blood. The H1N1 swine flu outbreak began in Mexico and is technically termed as swine flu because it is thought that occasionally pigs transmit the influenza virus to people. It spread through respiratory droplets with signs and symptoms similar to those of the actual flu. Now let's talk about COVID-19. The exact source of this virus is unknown, but the first infections were linked to a live animal market in Wuhan, China, and is spread by respiratory droplets through coughing and sneezing. SARS, or severe acute respiratory syndrome, is a disease or syndrome caused by the coronavirus. To date, there have been over 10,000 deaths from COVID-19 just in the United States. With any pandemic, individuals become worried that they have the virus. They are known as the worried well. Even though they don't have any symptoms, they want evaluation, they want preventative treatment, and/or reassurance from a healthcare provider. Decontamination is the neutralization or removal of dangerous substances, radioactivity, or germs from an area, object, or person. According to the United States Environmental Protection Agency, the three most frequently identified zones include the exclusion zone or hot zone, which is an area with actual or potential contamination and has the highest potential for exposure to hazardous substances. The contamination reduction zone or warm zone is the transition between the exclusion and the support or cold zone. This area is where responders enter and exit the exclusion zone and where the actual decontamination activities take place. The support zone or the cold zone is the area of the site that is free from contamination and that may be safely used as a planning or staging area where workers can obtain a change of clothes, get a healthy non-perishable snack, water. It will have a first aid kit. There'll be over-the-counter medications such as ibuprofen, acetaminophen, and antihistamines. There'll be flashlights with extra batteries, and wall plug USB cell phone chargers can also be found in this cold zone area. The goal to all mass casualty events and the goal of emergency preparedness is to effectively meet the needs for resources such as hospital beds, staff, drugs, personal protective equipment, PPE, supplies, and medical devices such as medical ventilators. The United States tries to stockpile critical equipment and supplies in case they were needed for a pandemic outbreak. Each state and local healthcare facilities should also have their own specific emergency preparedness plan for a mass casualty event. This is done through drills and training as well as stockpiling the PPE and medications as needed. We have seen, especially with the crisis we are currently in, the need to be prepared in case it's necessary that we be quarantined for a 2-week period of time. The above says a 3-day supply of food, but it would need to be 2-week supply of food, etc., for the mass casualty event that is currently going on right now. Bystanders will always be the first on the scene of a disaster, so through public education, stopping the bleed can occur before emergency services arrive. Usually notification occurs through cell phone communication, by radio or electronic communication between emergency department and emergency medical service providers at the scene. At this point in a mass casualty situation, because of disaster preparedness, each hospital should have a plan for notifying essential personnel of the event, whether it be through group paging, a telephone tree, or an instant computer-based automated alert system. If it's a catastrophic event, such as an earthquake or tornado or terrorist attack, teamwork and interprofessional collaboration with volunteers are contacted as well as the media. In these cases, the National Guard, the American Red Cross, the public health departments, and military units or disaster medical assistance team can be activated by state and/or federal agencies. At the facility level, it's called the Hospital Incident Command System, or HICS, which is part of the Federal Emergency Management Agency, also known as FEMA, and the Department of Homeland Security that heads up the National Incident Management System. Officers are named to oversee essential emergency preparedness functions. These officers include the Hospital Incident Commander, Medical Command Physician, Public Information Officer, and the Triage Officer. And it's very important that you know what the roles of each of these individuals are. The hospital incident commander is the person responsible for all aspects of the emergency response, including quickly developing incident objectives, managing all incident operations, application of resources, as well as the responsibility for all persons involved. In other words, they're the individual that assumes overall leadership for implementing the emergency plan. This could be a physician, or it could be a hospital administrator as well. A medical command physician communicates with and issues medical commands ordered to the EMS providers when they seek direction. They're the ones who decide the acuity and the resource needs of the clients. Public information officers gather facts and distribute them to the media. They produce printed and video material about their organization for dissemination to the public. A public information officer may be responsible for organizing special events such as news conferences. In other words, they are the liaison between the healthcare facility and the media. The duties of the triage officer role include ensuring the triage of all victims and directing or determining the movement of patients toward the treatment transport areas during a mass casualty event, and it depends upon the level of care needed. This role may be assigned to a physician or a nurse. These are additional staff that can comprise the incident command system structure, two of which we have already talked about on the previous slide. Again, the incident commander sets objectives, maintains overall leadership responsibility, and that individual is often the disaster commander. The liaison officer coordinates efforts between agencies. Public information officer is the liaison between the hospital facility and the media. Safety officer is responsible for worker safety, specialized skills paired with disaster needs. The operations section chief conducts operations, directs resources, and oversees the decontamination and waste control. The planning section chief develops action plans, collects and evaluates information, and maintains resource status. Logistics section chief provides resources and support for incident needs. Finance administration section chief monitors costs and provides accounting figures. But the previous slide that shows the four individuals are the most important that we need to know about. Don't forget that incident is used interchangeably with disaster or event. These local, regional, state, and federal assets may include money, equipment, even personnel from outlying areas, as well as other assets. Everyone must follow the guidelines of the incident command system structure because there could be negative consequences if they're not followed. Field medical triage is not the same as hospital triage. The number one priority outcome of field medical triage is to do the greatest good for the greatest number of people. This means that patients who are critically ill or injured and might otherwise receive attempted resuscitation during usual operations may be triaged to a patient that is expectant to die and not be treated until others receive care. The rationale for this difficult task of triage is to save the most lives rather than expending valuable resources and time to save one life at possible expense of many others. Also listed on the slide are other triage priorities. Nurses must be a part of the internal and external emergency response plan, which includes security needs, communication methods, training, alternative treatment areas, staffing for high demand situations, requirements for resources, equipment, and supplies. Then they test the plan by actively participating in disaster drills and evaluate the outcomes. During an actual disaster, hospital emergency department nurses collaborate with the emergency department nursing leadership and the trauma program manager, as well as the medical command physician and triage officer, to organize nursing and ancillary staff to meet the client's needs. You're going to have another lecture that discusses how to triage in an emergency department. It's important to know that nurses in all areas within the facility must collaborate with the healthcare provider to determine who can safely be discharged to free up inpatient beds for disaster victims. The medically stable can be considered for discharge, which include those admitted for observation and are not bedridden, are having diagnostic evaluations and are not bedridden, are soon scheduled to be discharged or could be cared for at home with the support of family or home health services, have not had critical change in their condition for the past 3 days, or those who could be cared for in another healthcare facility such as a rehab or long-term care facility. Critical care nurses can collaborate as well with the primary care physician to identify patients who can be transferred out of the unit, expanding critical care bed capacity. General staff nurses may be recruited to care for stable emergency department patients. Critical care nurses can be used in the emergency department to assist with closely monitoring patients and aid in transporting patients to the critical care units. Inpatient nurses may be assigned a higher number of patients to care for, and care may need to take place in the non-traditional areas such as the hallways or in lounges. Some staff may even have their roles changed completely, such as a supervisor may have a full clinical assignment. Everyone needs to be flexible. Remember, the greatest good for the greatest number of people is still the organizing principle in mass casualty event. Patient safety is vital. What would you do if an explosion, bombing, or event which created a large number of injured or dying people happened while you were working? How would you care for the injured? How would you sort priority of treatment? How would you prioritize transport? The answer is you would use the START, S-T-A-R-T, tag triage system, and START means it's abbreviations for simple, triage, and rapid treatment. Triage is the process of prioritizing or sorting of the sick or injured people for treatment according to the seriousness of the condition or injury. You have primary triage and secondary triage. Primary triage is the first contact where you assign a triage category, and there's very little documentation. Secondary triage is an ongoing process that takes place after the patient has moved to a treatment or holding area awaiting transport. More assessment and treatment will be done with the secondary triage. The first responders are usually the ones that remove the victims from danger, both the injured and the uninjured. Situational awareness and appropriate priority setting and safety is very critical in the field. We have already discussed how you can't commit to one-on-one care, and you have to be fast when you triage in the field, which means 30 seconds or less per patient. Remember, look, listen, and feel. Use your eyes, ears, and hands. Make sure the scene is safe first. You can yell out for anyone who can hear you to walk towards your voice and come to you. This clears out the minor injuries and those with low likelihood of death in the immediate future. These are tagged green and are called the walking wounded. If they are able to listen, understand directions, and get up and walk on their own to a specified area, then the chances of them dying in the next hour is low. As soon as enough medical resources arrive on location, the green tagged victims will need to be re-triaged to look at for more serious conditions. These individuals can also be helpers. As far as burns go, first degree and superficial burns constitute a green tag. What are the different triage categories as part of the START triage system? We've talked a little bit about the green tag. That's the walking wounded and do not require immediate treatment and include examples such as a closed fracture, sprains, strains, abrasions, and contusions. Yellow tag are patients who require treatment but can wait a short period of time before care, like an open fracture but they do have a distal pulse or large wounds. Red tag individuals have injuries that are an immediate threat to life, such as an airway obstruction or shock or need immediate attention. Black tag victims are those that are expected and allowed to die or are already dead. Also remember that even the greens and yellows could deteriorate, which is why a secondary triage is necessary. Designate someone to stay with each tagged group other than the black tagged group, so in case someone does start to deteriorate, they can move up in higher triage. We need to remember RPMs, but first we have to see if they have the ability to follow directions and walk toward us. Then comes the R, respiratory effort, P for pulse/perfusion, and then M for mental status. This slide reiterates the previous slide on triaging in the field. Again, we have to remember the overall outcome of triaging in the field. We're doing the greatest good for the greatest number of people. This, again, means the inability to give one-on-one care until they get to the hospital, which is necessary but sad. The triage tag on the slide gives you a quick guide to tag designation. This is how to triage an adult because children are a little bit different. We're going to use the START tag triage system. And what does START mean again or stand for? Simple triage and rapid treatment. We already talked about the walking wounded. So if they can walk, they're considered a green tag. Respirations. If they don't have any respirations, manually open or reposition the airway with the jaw thrust or head tilt. If they start breathing, tag them red. But if they do not start breathing, tag them black. We cannot start CPR when resources are not adequate during a mass casualty event. If they are breathing greater than 30 breaths a minute, tag them red. If under 30, we must next assess pulses, perfusion, and circulation status. Check the radial pulse because if they have perfusion to the periphery, then we know the organs are being perfused. If you answered yes to pulse, then go directly to the mental status. Remember, the pulse rate does not matter. What matters is whether they have a pulse or not. No pulse, you can tag them as red and move on, or you can check cap refill. Cap refill could be delayed depending upon the environmental temperatures, but if a cap refill is over 2 seconds, then assess for obvious bleeding and have someone put pressure on the area and tag them as red and go on. Mental status, can they or can they not follow commands? And it can be a simple command like have them touch their finger to their nose. If they can follow commands, then tag them as yellow. If they cannot follow commands and you're confused in any way, if they're confused in any way, tag them as red. Sometimes all you have to see or know is are they confused, disoriented or not, and you can automatically know that they're going to be tagged as red. Again, to reiterate the yellow, if they have respirations under 30, radial pulse is present, or cap refill is less than 2 seconds, and they can follow commands, then they will be tagged as yellow. All babies under 1 year of age always gets a secondary triage, meaning there will never be a green tagged infant. Then follow Jump Start system to determine if they're yellow, red, or black. The Jump Start triage is designed for children aged 1 through 8. Respiratory effort, not breathing. Open the airway. If the child starts breathing, tag them red. If they're apneic and no pulse, tag them black. If they're apneic with a pulse, you can try 5 rescue breaths. If they're still apneic, tag them black. If they start breathing after 5 breaths, tag them red. Respirations between or less than 15 or greater than 45, tag them red. Respirations 15 to 45, go to the pulse section. No distal pulse, tag them red. Radial pulse present, go to the mental status using the AVPU, alert, response to verbal stimuli, response to painful stimuli, or unresponsive. With the alert, response to verbal, and response to pain, tag them yellow. Inappropriate responses, posturing, or unresponsive, tag them as red. See if you can tag these victims appropriately. What tag will they be? If you answered red, black, and green to the previous slide, then you got them all correct. This slide speaks for itself. Secondary assessments are a must. The victim may deteriorate, and this needs to be identified early on. A tornado hits the community college. The chemistry lab is hit the hardest. There were 32 students in the lab. The classrooms adjacent to the lab were also damaged. There are approximately 250 students injured, some potentially dead. A fire breaks out in the chemistry lab at the time the EMS and first responders arrive at the college. There are people trapped and many people are unable to ambulate. Let's think through this scenario. So with the above mass casualty, what kinds of injuries do we expect? What is the chain of events that will happen? And how will the hospital prepare? See if you can think of any other expected injuries, or is there anything else to add to the chain of events? And what about how the hospital will prepare for incoming victims? A mass casualty event is very stressful, and of course supplies need to be restocked, but debriefing and support or psychosocial health is a huge priority for everyone involved. We also can't forget about eating. Food is important. Administrative review of the disaster event occurs afterwards to analyze the hospital or agency's response to the event, like what went right and what went wrong during activation and implementation of the emergency preparedness plan, so that changes can be made if necessary. Feedback is essential in preparing for future events. Coping abilities are severely stressed after an event, so referrals may need to be made to social workers, psychiatric mental health specialists, or mental health counselors, or support groups to promote effective coping.